Hello, and welcome to this week's episode of Medisodes. This week, we're talking about malaria. Malaria is a disease carried by mosquitoes. The mosquito bites the person and transmits a parasite that the mosquito carries, causing malaria. Let's investigate why malaria is such a big issue in the world with Anupam.
So, as a disease, malaria has plagued the human race for millennia. Although the parasite responsible for the dominant strain of malaria has been in existence for between 50,000 to 100,000 years, the population size of the parasite did not increase significantly until about 10,000 years ago, concurrently with advances in agriculture and the development of human settlements. References to the unique periodic fevers caused by malaria are found throughout history, even by the likes of Hippocrates, father of medicine. The term malaria itself originates from medieval Italian mala aria, or bad air. The disease was formerly called ague or marsh fever due to its association with bad air surrounding swamps and marshland, prime breeding grounds for the mosquitoes, which are the disease's primary vector. Malaria parasites belong to the genus Plasmodium, and in humans, malaria is caused by 5 primary species: P. falciparum, P. malariae, P. ovale, P. vivax, and P. noalese. Among those infected, P. falciparum is by far the most common species identified, in over 75% of cases, followed by P. vivax, which is in around 20%. Although P. falciparum traditionally accounts for the majority of deaths, recent evidence suggests that P. vivax malaria is more commonly associated with life-threatening conditions, about as often as a diagnosis with P. falciparum infection. It's also interesting to note that P. vivax is proportionally more common outside of Africa. The signs and symptoms of malaria typically begin 8 to 25 days following the actual infection, but may occur later in those who have taken anti-malarial medications as prevention. The presentation of the disease may include headache, fever, shivering, joint pain, vomiting, anemia, jaundice, blood in the urine, retinal damage, and convulsions. However, the classical symptom of malaria is paroxysm, a cyclical occurrence of sudden coldness followed by shivering and then fever and sweating. Beyond this, malaria has several serious complications. Among these is the development of respiratory distress, which occurs in up to 25% of adults and 40% of children with severe P. falciparum malaria, and in most cases causes death, if not properly treated in time. However, malaria's effects stretch beyond the health implications. Because it's not just disease commonly associated with poverty, some evidence suggests that it is also a cause of poverty and a major hindrance to economic development. A comparison of average per capita GDP in 1995, adjusted for parity of purchasing power, between countries with malaria and countries without malaria gives a 5-fold difference. And in the period 1965 to 1990, countries where malaria was common had an average per capita GDP that increased only 0.4% per year, compared to 2.4% per year in other countries. As well as this, poverty can increase the risk of malaria, causing a vicious cycle to form. In its entirety, the economic impact of malaria, in Africa especially, has been estimated to cost $12 billion of losses every year. This includes costs of healthcare, working days lost due to sickness, days lost in education, decreased productivity due to brain damage, and loss of investment in tourism. I'm now going to go into some of the stats from recent years concerning malaria. Globally, in 2019, there were an estimated 229 million malaria cases in 87 different malaria endemic countries. However, this is a decrease from 238 million in the year 2000. 29 countries accounted for 95% of malaria cases globally, the top 5 being Nigeria, the DRC, Uganda, Mozambique, and Niger. Together, these account for 51% of cases globally. The World Health Organization's African region accounted for 94% of cases, and although there were fewer malaria cases in 2000 in the Africa region compared to in 2019, This is due to the complexity of interpreting changing disease transmission in a rapidly increasing population. For reference, the population living in the WHO Africa region increased from about 665 million in 2000 to 1.1 billion in 2019. Globally, malaria deaths have reduced steadily over this 20-year period, from 736,000 in 2000 to only 409,000 in 2019. And about 95% of these malaria deaths were in 31 countries, the top 5 again being Nigeria, the DRC, Tanzania, Mozambique, and Niger. Since 2015, however, the WHO European region has been completely free of malaria. The WHO African region, however, carries a disproportionately high share of the global malaria burden. In 2019, it was home to 94% of both cases and deaths. Total funding for malaria control and elimination also reached a high in 2019, hitting an estimated US $3 billion. Contributions from governments of endemic countries amounted to $900 million, representing 31% of total funding. The funding gap between the amount invested and the resources needed has also continued to widen. However, scale-up of interventions has saved millions of lives globally and cut malaria mortality by 44% from 2010 to 2019. So it's clear that malaria has a huge impact on the lives of millions of people around the world, not only affecting the way they live, but also the way they go about business, even affecting things on a countrywide level. But how does this disease actually spread? For that, we're going to move on to Adrian.
I'm now going to be talking about the transmission of malaria. An understanding of the transmission mechanisms of malaria is important in managing its spread and helping control outbreaks of the disease. Malaria can be a potentially fatal disease, and so it is important to understand its transmission so that the rate of spread can be controlled. The necessity in understanding its means of transmission is not unlike that with COVID-19, where understanding its means of transmission allows for measures such as lockdowns and mandatory masks to be put in place, which reduces the rate of infection and pressures on healthcare systems. For content on COVID-19, be sure to check out our COVID-19 playlist, containing all the episodes we've done covering COVID-19. While discussing the transmission mechanisms of malaria, I'm going to be comparing it with COVID-19, because the two diseases are transmitted in very different ways, but cause similar symptoms, including a high temperature, headaches, and muscle pains. Usually, people get malaria by being bitten by an infected female Anopheles mosquito. Only mosquitoes of this species can spread malaria. Only female mosquitoes bite to provide nutrition for their offspring. Whilst COVID-19 is caused by a virus, malaria is caused by a type of parasite called Plasmodium. There are many different types of Plasmodium parasite, but only 5 are known to cause malaria in people. This parasite is spread by the aforementioned female Anopheles mosquitoes, mainly at dusk or night. When an infected mosquito bites a person, it passes the parasite into the bloodstream. Malaria can also be spread through blood transfusions and by sharing needles, but this is very rare and can be avoided altogether by using proper medical equipment hygiene and sanitation. Malaria can also be transmitted from a mother to her unborn child before or during delivery, and this likely results in the death of the child, for they do not have a sufficient immune system to fight off the parasite. Then, when an uninfected mosquito bites an infected human, the mosquito picks up the parasite, which is then passed on to another human. In this way, mosquitoes are the vectors for transmission from human to human. Note that malaria cannot be transmitted from person to person like the cold, or, indeed, COVID-19. The only way it can be transmitted between people is through sharing of blood, and so the spread of malaria is much less than that of COVID-19 from person to person. This means that, in managing the outbreaks of malaria, measures such as lockdown and masks will not help, for malaria is transmitted differently. However, there are other ways in which one can reduce the risk of developing malaria, and they are linked to the way that malaria is most commonly transmitted. The first is bite prevention. If you take measures to reduce the risk of being bitten by a mosquito, you reduce the risk of being infected by malaria. Bite infection is a wide umbrella used to refer to ways in which one can reduce their risk of being bitten by a mosquito. Shrey will go into these and further prevention measures in more detail later on in the episode. Now, I'm going to go through a detailed life cycle of the malaria parasite, starting at the point where the female Anopheles mosquito bites the human. When the human is bitten, the mosquito injects sporozoites into the blood. Sporozoite refers to the mobile, spore-like stages in the life cycle of some parasitic organisms, and it is typically the infective agent introduced into the host. The sporozoite then infects the liver cells and uses the cell's mechanism to replicate by mitosis. The liver cells rupture and merozoites are released. Merozoites refers to a stage in the parasite's life cycle that is capable of initiating a new cycle of development and reproduction. After several asexual stages, the merozoites produce gametocytes instead, and these gametocytes are transmitted to the mosquito when it bites an infected human. The gametocytes undergo meiosis and mate in the mosquito to form an egg cell. This then leads to the development of further sporozoites in the mosquito, which are then transmitted when the mosquito bites another human, and so the cycle starts again. From this, we can see that both hosts of the parasite, the human and the mosquito, are essential in the spread and transmission of malaria. In the human, the liver cells especially are essential, and the mosquito is needed for the production of sporozoites. If we can break a part of this cycle, then we can reduce the spread of malaria. Bite prevention, as I've mentioned before, causes a break in the cycle at the parts where the parasite is transmitted between human and mosquito, and vice versa. However, there are other places in the life cycle of the malaria parasite that can be targeted when trying to reduce the spread of the disease. For example, gene modification experiments have shown that they can change the physiology of the mosquito, such that they are no longer able to transmit the virus to humans. This breaks the chain of transmission in a different place, and so requires less change to people's lifestyles, and is also more effective. Now I'll hand over to Surya, who'll be talking about treatments for malaria.
To treat malaria, patients need to take anti-malarial medication, and these medications are taken when traveling to countries where the risk of infection of malaria is very high. A GP or local travel clinic will advise on whether to take these anti-malarial drugs. Taking malaria medication as a preventative measure when going to a high-risk malaria area reduces your chances of developing malaria by 90%. The medications you are prescribed depends on several factors such as medical history, family history, allergies, age, type of malaria, and for women, whether the type of malaria medication prescribed can depend whether they are pregnant or not. The first anti-malarial drug we will be looking at is chloroquine, which can be used to treat rheumatoid arthritis as well as malaria. It requires a prescription and is usually found in tablet or liquid form. However, as with many other medications, there are side effects to this drug, and these include headaches, dizziness, hair loss, and low blood sugar, to name a few. This drug is not recommended commonly in the present day because of its ineffectiveness against the most common type of parasite, which is the Plasmodium falciparum. Therefore, chloroquine is more commonly prescribed to people who are traveling to areas such as India and Sri Lanka, where Plasmodium falciparum is less common than other malarial parasites. Since Plasmodium falciparum is resistant to chloroquine, a potential drug that can be used to treat malaria caused by Plasmodium falciparum is known as quinine. It is important to note that quinine is not used to treat severe cases of malaria and shouldn't be used to prevent catching malaria in the first place. Headache, chest pain, and severe dizziness are all severe side effects of the drug, and tachycardia, bruising, or bleeding can also be side effects. Quinine should not be taken if you have a heart rhythm disorder called long QT syndrome, optic neuritis, which is inflammation of the nerve cells in your eyes, or if you have liver or kidney diseases, to name a few conditions. Mefloquine, also known as Lariam, is used to treat mild malaria but can be used for malarial prevention. If you haven't taken mefloquine before, it's recommended you do a 3-week trial before you travel to see whether you develop any side effects. Some common side effects include dizziness, headache, insomnia, which is a lack of sleep, anxiety, depression, panic attacks, and hallucinations. Due to the mental health side effects that can arise due to Lariam, it is important to tell your doctor about any mental health conditions you may have. before you're prescribed the medication. Now let us move on to Shrey, who will be discussing the prevention of malaria.
So, as with any medical condition, prevention is better than cure. Unfortunately, there is no vaccine for malaria, although scientists are working on it. In the absence of this, we need to be aware of risk and also prevent bites, as Adrian mentioned earlier. So, concerning awareness of risk, if you're traveling abroad to a place where malaria is present and highly prevalent, you need to make sure that you're taking the correct precautions, such as taking anti-malarial medication. And to do this, you can look at the Fit for Travel website or talk to your GP. And it's important to note, even if you grew up where malaria is common, no one has complete immunity. And even if you do have some immunity, it's quickly lost. So even if you think you are immune, you should still be taking that anti-malarial medication. But by far, the most important thing, especially for people who live in areas where malaria is prevalent, is bite prevention. If there are less bites, there's less chance of you getting malaria. And the most effective way to prevent bites is an intact mosquito net, preferably sprayed with insecticide. And these can be made of polyester, polyethylene, or polypropylene. And they work in two ways. Firstly, they provide a mechanical barrier for the mosquitoes, which means that the mosquitoes cannot physically reach you. And also, they provide a chemical barrier due to the insecticides. And the main insecticides used are pyrols and pyrethroids. These chemicals work by knocking down the mosquito and killing it. It's estimated by the Against Malaria Foundation that malaria nets are 99% effective, even if they have holes in it, and that's due to the insecticides killing mosquitoes before they can get through the holes. Then extremely cheap, one malaria net is estimated to be about $2, and these can last up to 3 to 4 years. And this is a recent breakthrough. In the past, malaria nets have only worked for 6 months to a year, which has made them largely ineffective. But with these longer life malaria nets that can last for 3 to 4 years, it's really helped to prevent malaria. And each malaria net can protect about 2 people, depending whether they're adults or children. And it's estimated that for every 600 malaria nets that they use, 1 death is prevented and 500 to 1,000 cases of malaria are prevented, which is obviously amazing. Also, if in a community over half of the people use these insecticides treated nets, it provides protection to the whole community due to the reduction in the number of mosquitoes and also the lifespan of the mosquitoes. And huge efforts have been made to give malaria nets to people, especially in sub-Saharan Africa. So the CDC estimate that between 2008 and 2012, 294 million nets were distributed in sub-Saharan Africa. The WHO show that and data from the WHO shows that in 2000, only 2% of the population in malaria risk areas had nets. But by 2019, 46% of them had this. And this is obviously amazing progress, although this level of nets is plateauing slightly. So it's also important to use insect repellents to repel the mosquitoes away from the skin. And the most effective one is diethyl toluamide, otherwise known as DEET. And it's important to note, if you are spraying on DEET, you need to make sure that you do it after sunscreen rather than before, because otherwise it's largely ineffective. And going away from mosquito nets and insect repellents, wearing light, loose-fitting trousers rather than shorts, and long-sleeve shirts, especially during early evening and night, can help to prevent mosquitoes biting you by leaving less skin exposed. And this is especially important during the night because mosquitoes are most active between 10 p.m. and 2 a.m. So especially during the night, we need to make sure that although it might be hot, we need to make sure that you're covering up your skin to make sure that you're preventing bites. Further, there is no evidence that homeopathic remedies, electronic buzzers, vitamins B1 or B12, garlic, yeast extracts like Marmite, bath oils, or any of these types of treatments provide any protection against mosquito bites. If you want to learn more about alternative medicine, be sure to check out our video on that. So we've discussed why malaria is such a prevalent disease, how it's transmitted, how it can be treated, and most importantly, how it can be prevented. I hope you've enjoyed this week's episode, and be sure to check out our other videos and stay tuned for next week's video.